Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Today, our topic is on the Nocebo Effect, When Words Make You Sick, which is a new book with two of the authors. So, Charlotte, maybe you want to introduce yourself.
Okay. So my name's Charlotte Blease. I'm a researcher at Uppsala University in Sweden, and I'm affiliated to digital psychiatry at Harvard Medical School at Beth Deaconess Medical Center there. And my background is very interdisciplinary as a health researcher. And one of the topics I've been interested in is the placebo effect and the nocebo effect, which we'll get into.
Great. And Cosima, can you introduce yourself?
Yes, thank you, Ben. So my name is Cosima Locher. Yes, exactly. I'm based at the University of Zurich, which is in Switzerland. My background is I'm a psychologist, and I'm primarily interested into the placebo research, but also ethical considerations, health in general, and chronic pain primarily. Yes, exactly.
Great. So the placebo effect is basically, my understanding is, when someone, such as a patient, feels better after taking a sugar pill or some other treatment that is generally not thought to be able to help them with whatever condition or symptom they're dealing with, such as pain. It's generally thought that they feel better or their condition improves because they feel that they have been given a pill or a treatment that will help them. If they've been told that it will work and they have confidence in that, it increases the likelihood that they'll feel better. Now, we often conduct scientific studies to prove the efficacy of drugs and medical treatments by comparing a group of patients that take the pill with the active medication and another group that takes a identical pill that doesn't contain the medication, what we often refer to as, say, a sugar pill. Now, the placebo group is generally not expected to improve while the group that gets the medication is, except that we've discovered over time that a significant percentage of patients who get the placebo group, who get the placebo treatment or pill, actually do improve. And so this has been referred to as the placebo effect, and there's been a ton of research going on about this. And the nocebo is sort of the opposite of the placebo, in that if the patient believes or has fears or expectations that they are likely to have side effects or a negative result from a medication or a treatment, they may have such negative effects. The book, The Nocebo Effect, When Words Make You Sick, is designed to bring awareness to the nocebo concept, which has been much less researched than the placebo effect. And this book also attempts to bring some solutions so that nocebo effects occur less frequently. Perhaps you can both weigh in a little more on what exactly is a nocebo effect and why this is an important concept.
Sure. I can kick us off. The nocebo effect, as you've sort of characterized it, is often just sort of depicted as the sort of malevolent or evil twin of the placebo effect. So it is this effect that arises when patients or people in general anticipate some adverse health outcome. And they may have learned this health outcome somehow through medical encounters. As this is something that we discuss, and our contributors in the book discuss in various ways. So that words matter in medicine. What your doctor says to you matters, or your psychotherapist. Something that Cosima has written a lot about. But also what you believe is going to happen or what the outcome is going to be can affect your health, potentially in a negative way.
Right.
Yeah, I would align, of course. This is all very important also for clinical practice. So this is also something I'm quite interested in, to look what happens then in the clinic. And if you think how doctors, for example, introduce when they give a medicine, what this can also have in terms of side effects, that this is very crucial, the way how this information is being given. So we also talk about this in our book. Primarily, I think Mette Sieg and Lene Vase talk about what can clinicians do to minimize this information about side effects. So this is very hands-on also in clinical practice and very relevant, and it can really make a change. So words are very powerful also in the opposite way, as you said, the counterpart of placebo.
Yeah, I do think that that's some really important points. I do think that it's underappreciated from both patients and even practitioners how important the placebo and the nocebo effect are. And I think a lot of physicians don't necessarily think about it as much as they should in their communication with their patients. One of the things that I was surprised to read about in your book was actually when you remarked that 53 to 89% of physicians in the US actually knowingly prescribe placebos to their patients, meaning they're giving them a treatment that they don't think it really has the ability to help them, but they do it just because they want to help their patients, and they tell the patient that it's going to help them.
Yeah, it's a fascinating finding. And what's interesting is that you see in lots of countries worldwide, these kinds of surveys have been conducted among clinicians internationally. And you do find sort of, depending on the sample size, but quite high percentages of doctors say that they do this. We've done some survey work. I did some survey work in the States, in Boston, on this. One of the things, there are a variety of reasons why doctors do this.
Okay.
So some of them, they do want to offer something. Some of it's a bit of a performance anxiety thing, that they want to be able to offer the patient something. Sometimes they don't know what to offer, and they're not sure what's going to work. And they might present, and this is like what Cosima is saying, words matter. The performance, the presentation of what it is you want to offer the patient might influence them to think that this might, if you will, engender some hope. So it's this balancing.
Do you have maybe one or two examples of what a physician might offer a patient in this situation?
Yeah, so it may be that they're not. Fatigue is one of many who isn't feeling tired, but a lot of the time when people go to the doctor, they might say, "Look, I'm not getting any sleep. I'm excessively tired," and that could be a really serious underlying health problem. But if a patient presents with that in combination with other symptoms, perhaps the doctor might offer them or suggest a vitamin or something like that. They might suggest some dietary supplement.
After all, since we know vitamins can have no benefit. Just kidding.
Well, it's this issue
coming from somebody from the functional medicine world.
Right. So it's this sort of gray area where you're suggesting something, and in this case, the pill's going to do, or the Medicare or the vitamin or the supplement, whatever, could do something to the patient. But is it also, in addition, or potentially going to elicit a kind of placebo effect? Are they going to feel a little bit better? And it's these kinds of nudges where we get into the gray area between transparency, being completely honest, and the doctor saying, I don't really have anything to offer, versus wanting to offer something to give some kind of hope or potential benefit.
I would like to also posit that I suspect that one of the reasons why in the United States, physicians may feel compelled to offer some medication, even if they know that they're likely have no medications that really address the problem, is because of our healthcare system, which is essentially run by insurance companies, require doctors to have very short office visits. And you need to get in and out of that room, and the patients want to feel like they've been given something. So I think there's a tendency to prescribe something. And so a situation that I've seen over the years very commonly is a patient comes in with a cold or a flu, which we know is caused by a virus.
Yeah.
We have no medications that really control viruses for the most part. So they're given a prescription for an antibiotic, and then the patient feels like that's going to help them. And I think the physicians feel like, okay, now I'm done with the visit. I did something to satisfy the patient. And unfortunately, it sometimes has untoward side effects. Like in this country, we have this overuse of antibiotics that have led to virus bacteria that are not responding to antibiotics anymore.
Right. I think that's a universal concern in Western countries, this overprescribing of antibiotics. And as you say, it's the classic example, antibiotics for a viral condition. And it's offering the patient something.
Right. Yeah.
And I think it's very important. I think this is a very important, of course, explanation of looking at the doctor's side and what is happening. And you have this very limited, hour and time. This is also something that is, I think, also very common in several countries. But it's also when you look at the patient, for example, I did a lot of research in the field of chronic primary pain. So where, it's not about the etiology. So in chronic secondary pain, we know what happened, for example, a broken leg or whatever, or pain because of cancer or because of an accident. But in chronic primary pain, according to the new ICD-11, it's quite unknown what is the etiology. And these patients, they do really suffer and they have real pain, and they do often doctor shopping. So they want to have something that helps them. And I think, Charlotte, what you mentioned with hope is so important, right? They really have this desire for relief, and they are desperate. And this is very, very understandable. And I think what happens there is also this feeling of, I have to give this patient something because this patient is now in a really bad state. And there are studies which really show that when a physician can do something, in comparison, when the physician is somehow feeling himself or herself helpless, this gives, in the brain, a kind of a benefit. So I think this is obviously also what physicians have and want to do, right? Helping their patients. So this is all quite complex, I would say. Yeah.
Definitely.
Yeah. So let's switch to nocebo, and let's talk about some common situations in medicine where the most nocebo effect comes into effect. And you mentioned the use of statin drugs as a common situation, because so many patients have heard that statin drugs are going to cause muscle pain or brain fog or other symptoms.
Yeah, I mean, I think it's estimated about 200 million people take statins worldwide. But there's been some fascinating studies to show that when patients are given placebos in clinical trials of statins, that up to 90% of the side effects could be attributable to nocebo responses. So it's this interesting sort of confluence of public awareness through media. So media can play a role here. What you've read, it could be, some of it could be owed to a certain social contagion. So people anticipate through what they've heard on the grapevine, so to speak, from other people, other patients. But some of it may also be, and this is where we get into it in the book, what do we mean by nocebo effect? Is it the genuine anticipation this is going to be harmful that induces it? Or are people sort of saying that they've got some of these conditions, and they may have some underlying somatic complaint that they're attributing to this statin. So it's disentangling these is another aspect of really getting into the science, and it's complicated. You're going to hear us saying everything's complicated. This is a really complicated area, and it's important not to be too reductive about it. But and this is why this book is so important, because there really hasn't been anything published on this evil twin, this nocebo effect, and how best we study it and what exactly it is, really homing in on it.
And certainly it's not as simple as it's just completely a psychosomatic thing, because there are patients who, like you just mentioned, maybe they do have some underlying muscle pain and had that before, and now they're attributing that to maybe taking a statin drug. There's some patients who are having a psychosomatic effect and they think they're getting muscle pain and they're not, but there are some patients who are actually getting muscle pain. Some patients who actually their health gets worse. And there's even been patients, right, who've been reported to have died from the nocebo effect. Isn't that correct?
I like Cosima to this controversial.
This is also complicated.
Yeah.
So there is this one famous study where a patient apparently felt like almost dying because he wanted to suicide himself, and he took a lot of these drugs, and he was currently in a study, a patient of a study, and then he wanted to suicide himself and took an overdose. And then in the hospital, it turned out that actually this person was in the placebo arm of the study. So I think there are many studies also, studies which are... And
that person died?
No, but almost, it
Okay.
looked as if, right, all the symptoms where you would say someone almost died. But I think these are, they're always case reports when you do... So when whatever field you're in, you have case reports. And of course, this is one line of how you can examine a phenomenon. But I think that it's also very important, of course, to do replications. So not even of a case, but also of a study. So usually when a phenomenon is new and people are very excited about it, we see that the effects are quite large, and we have maybe a power issue because we have small sample sizes. And then it's always very important, of course, to replicate the findings, to do network or meta-analysis and reviews. And I think the more we do that, the more accurate we can say. But
of course, you can't have a placebo-controlled study about nocebos, right?
Yeah, there are very interesting ways on how to examine nocebo effects, of course. Yeah. And I think one person once said most research has been done in the field of placebo because this is the usual control group. And when you do, for example, I did a lot of studies in antidepressants. When you do a placebo study and an antidepressant study trial, then you also have the nocebo effect there, because you can look whether the two arms, antidepressant and placebo, differ in terms of the appearance of side effects. So then you have the nocebo in there as well. And I think Charlotte mentioned, right, that we have with statins so many side effects. And the thing is, it really matters how you frame side effects, whether you say 2 out of 10 people have whatever nausea, or whether you say 8 out of 10 do not have nausea. So there is a systematic review which really showed that this makes quite a big difference, whether you positively frame it or negatively frame it.
Well, actually, let me put what I mentioned as a possibility as a question. Do we have cases of patients who have parameters about their health, whether they be measurable biomarkers or other parts of their condition, that get worse as a result of nocebo?
So I can give you one example of and this again, just to caveat this with what Cosima is saying, we do need, part of this book is an invitation to other researchers. We need replications of these studies. We need larger sample sizes, but a really interesting study with people with dust mite allergy, and giving them a milkshake with the allergen in it. And sort of, in a sense, teaching. It was like a bit like Pavlov's dog. You've heard of Pavlov's dog with the bell ringing, and then the dog salivates. Every time the bell rings, the dinner is there, and then you just need to ring the bell, and the dog's salivating, ready to eat. But this was, in a sense, sort of looking at this possibility of conditioning with nocebo effects with patients. And what they found was presenting them after this learned sort of conditioned response, that you could offer the milkshake and you would get this sort of, the inflammatory biomarkers were there among patients, as if they had been given, a touch of the allergen. So again, we need more of these kinds of studies, but there is some interesting work. Other studies are on what's often been called anticipatory nausea. So you can induce motion sickness, for example, give people fruit juice or something, induce motion sickness, the same sort of setup, and then just offering them the juice will make them feel a bit ill. So, and this is really important, of course, so many drugs, cancer, many medications lead to this kind of side effect that puts people off taking the medications. So anything we can do to minimize these kinds of effects where possible is going to be critical.
Yeah, and I think it's also very important that the nocebo, so all the examples, right? Also in the book, we don't only focus on research where we have this nocebo placebo, because nocebo is always there also in a verum, in any kind of drug. So there is a very nice study where patients once openly reduce their drug. I'm not sure whether it was opioids or whatever. So they reduce whatever they take, and they somehow expect side effects, right? Because this is what you would expect with reducing opioids. And once this was openly done, so the physician, they know when they reduce their intake or infusion. And once it's unclear, so they say, look, there is this machine, you have this infusion, and over a longer period of time, at a specific point, this will be reduced, but we don't tell you when exactly. And we say that the side effects due to drug reduction, they are really different between this open and hidden reduction. And this shows that the nocebo effect is also present even if we don't have a placebo pill that is examined. So I want to really underline what Charlotte said, how crucial this is in clinical practice. It's not only if you prescribe a placebo, it's with every verum.
Yeah.
Now, you mentioned cancer, and you talk in the book about how the nocebo effect can come up in the context of cancer care. And this is a very complicated situation for doctors, especially if they're providing a patient with a diagnosis or making treatment recommendations about a life-threatening condition like a stage 4 cancer diagnosis. I personally have noticed a number of patients who were suffering with a metastatic cancer, stage 4. They really didn't have a very good prognosis. And then they were provided with some form of treatment, typically chemotherapy or some other drug that's supposed to help with the cancer. And it's my understanding from the situation that I've seen that the treatment was palliative, but the patients thought it was curative. And I don't actually know exactly what the doctor said to the patient, but the patients would come in saying, oh yeah, I'm getting better. I think this is going to cure it. And, either the doctor wasn't clear about how they explained it. I've heard of situations where doctors will not tell the patient exactly, how grim the diagnosis is, and maybe tell the family, or, it's a difficult situation for the doctor, because the doctor is required to make sure the patient understands the condition, it gives informed consent for treatment. On the other hand, if there is a glimmer of hope that the patient might get better, you've got to be really careful as a physician, or you should be careful not to just say, hey, you're almost certainly going to die. This treatment at best is going to give you a couple of months. Why would the patient even bother to do it?
It's a really tricky area. And as you say, the doctor is walking a tightrope between balancing these different ethical concerns. On the one hand, they were really required, and this is, for most of the history of medicine, doctors had a kind of therapeutic privilege. They didn't tell the truth to patients. They used their own discretion about what they thought was the right thing to do. From the mid-20th century, after the Second World War, some of the atrocities with Joseph Mengele, the Tuskegee syphilis trial in the States, we've reached a sort of an awareness that as part of medical ethics codes, patients should be respected, and they should be respected to make their own decisions about their treatment plans. We respect the patient's autonomy to make their decisions. And to do that, you've got to furnish them with the truth. And this is where the nocebo effect gets really tricky, because you want to balance honesty and openness with not causing harm to the patient. So in these cases,
maybe giving them some sense of hope,
or giving them hope and benefiting the patient. So the doctor wants to benefit the patient, maximize the treatment outcomes, optimize them as far as possible. First, do no harm, of course. So minimize sources of harm, including nocebo effects, which can have consequences. And as we say that, if you anticipate side effect, one of the biggest reasons that patients will quit is because they don't like side effects, quit a treatment plan. So balancing that with the patient's decision about what it is they want to do, and to think about what it is they want to do, weighing that up for themselves about what the best decision is against their values and so on. So this is not an easy area, and we do discuss this in the book. We have an eminent medical ethicist who's contributed, Marco Annoni from Italy, who has contributed a chapter on medical ethics and what it is you should do in these scenarios. And there are no clean answers to this. This is what makes medical ethics an interesting area of research. So it's tricky.
You give some recommendations for maybe ways that doctors can communicate the situation in, say, a cancer diagnosis that's not that good, but do it in a way that doesn't just totally, it minimizes the likelihood of the patients having a nocebo effect, essentially.
Yes, and some of that comes down to what Cosima said. It's the framing of the information. It's how you convey it, and it's also the framing, so the words that you use that can convey the same facts, but doing it in a way that might lead to a more beneficial response from the patient side. But there are also, some other suggestions that have been made are this idea of discussing with the patient that they might not want to know the side effects. So medical ethicists talk about authorized concealment. So you might have a discussion to say, look, there are some serious side effects here. Do you want to know them? This, I think, is perhaps more of a kind of philosopher's or medical ethicist theoretical dream. In reality, I don't think these things necessarily work, because we've all got the internet. Apparently, health searches are second only to porn searches. So it's one thing sitting with your doctor and saying, yeah, I don't want to know. And then you leave the doctor's office and you say, to hell with it. I want to find out you Google it, somebody tells you. And then
patients want to know. So when we look at surveys, right? They want to know. So this is also, I think, very important to mention that patients want to know. So basically the majority. Yeah. And I think it also comes down, besides all the strategies, authorized concealment, but also the way we frame and education. I think it always comes also down to the patient-physician relationship. So it really matters whether you trust your physician, whether you feel guided by your physician. And I think that will, probably be the best way of, concentrating on the positive or informative information. And also, I think it's important to know that, of course, positive expectations are good. So this is what we mean with we try to boost interventions but actually realistic expectations are the best. This is also what studies show. So it's good to negative expectations, of course, is not what we want. And this is also with, minimizing harm. But we don't want to be over positive. This is actually also harming patients. So I think it's about setting realistic but also empathic expectations in being in a trust-based relationship. So I think it all comes down sometimes to the relationship between patient and physician.
Yeah, I do think that that's something that physicians probably don't get that much training in, is how to effectively communicate with patients.
Mm.
I think what Cosima said in terms of like the relationship is so central. Patients actually want to get the information from their doctor. They get it online because, as you said, Ben, they have a very limited amount of time with the doctor. Doctors are under serious pressure too. Time is sort of the most vital resource in healthcare. So they will look online if they don't get that information, but they want to get it from the doctor. And it's about signaling, as Cosima has underlined, this if you overcompensate or you try too hard to instill hope and then you go overboard and the patient then doesn't quite trust. I have a very good friend who's got a rare condition, and she says, God, when they offer me another placebo, I know when they're offering me placebos, and I can't stand it because I don't trust them anymore after that. And on the other hand, she recognizes why some doctors may do this occasionally with her symptom managing a chronic condition. So it's this, again, balancing act between signaling competence and empathy. You understand that those are the sort of the two facets also of the demeanor of the clinician that can be important in optimizing a placebo effect response too, and potentially minimizing nocebo effects. But for that, you've got to be in the realm of honesty.
The last chapter in your book, you mentioned, or next to the last chapter of the book, you mentioned some of the social phenomenon involving the nocebo effect. And I thought this was a great title of a chapter. It's called From Genital Shrinking Panics to Humming Giraffes, the Many Faces of the Nocebo Effect. And so I guess there have been some social phenomenon in which the nocebo effect has taken place. And one of the things you mentioned is this Havana syndrome situation, which took place in Cuba. And I didn't really understand it that well, but apparently a bunch of Americans working in Cuba, working for the State Department, et cetera, had a whole series of symptoms. And there was this investigation into whether some new weapon was being used by Russia. And it sounds like from the latest information that there was really no evidence of some new weapon that caused these symptoms.
Yeah. Go ahead, Cosima. Yeah.
No, I think, it's very important. I think these chapters, we also have this media chapter, right, where we see how influential the media and social media, of course, are. And, also with the idea of, I think it goes vital, right? And people, they read, of course, in the internet and so on. And this is really crucial in our daily life. So I think we have to really consider new ways of communication. And what we saw, right, it's not, I think this shows really nicely, all these chapters show that this is not somehow a disentangled context between the physician and the patient, but rather more, we have to always consider the context. And this is also something that we know from placebo research. So it's a much more complex, again, than only this interaction between two people. So, and I think, again, we see with this example that you, I think, summarized really nicely, is that, of course, it's not going down to the sugar pill again. So it's much bigger, actually, what we can subsume under nocebo. Yeah.
And what I would add to that is it gets into disambiguating what the nocebo effect is here. So we do have these other, I mean, what happened with this, with Havana syndrome, or a more recent case, which our colleagues, Mike Bernstein and Walter Brown have written about, is the bed bugs situation. You might have read about it in if you start itching and so on, all of a sudden there's a bit of the nocebo effect. In France, in Paris, and then it was, people were staying in hotels and then traveling the rails.
I heard a little bit about it.
Yeah.
Maybe you can tell us more. I don't really understand it.
Yeah, so it was this outbreak of bed bugs in France, in Paris, apparently in hotels, and I'd been in France that summer, so I was have I picked up? You start to get this feeling, and I had a friend who was in France, and it became this slightly anxious thing, I suppose, in continental Europe, and people traveling on the trains, and where this thing was spreading, the bed bugs were spreading everywhere, and so it's this issue of, were bed bugs actually making people itch in bed, or was it really the source of it? I mean, it can be quite, you can get sores and so on. Or, I mean, I have a friend actually who came back from Venice, and she said, I'm convinced we've come back with bed bugs. And they did a search, they couldn't find any bed bugs. So it's this issue of the nocebo effect. Is it a case of, it could be social contagion sometimes, where we're reporting things, it's a social effect, sort of conformity to beliefs. We're picking up beliefs and we're communicating them to others. We think that, or it could be a little bit of it could be nocebo effect too, causing these issues, or it could be some sort of misattribution. There's a variety of things going on here, and which makes it a fascinating topic, but a really tricky one to disentangle.
Yeah,
especially.
And I think Steinkopf also, maybe just to add, Steinkopf also very nicely shows that the placebo effect itself is something very human and evolutionary adaptive, right? So we show signals, for example, when we have placebo effects. So when I'm in pain or because of a nocebo, I show signals, and this is like a signal theory of other people responding to me. And this is actually an adaptive thing that is happening, but it can be, as shown by this example, quite weird what is going on then when it goes viral.
Yeah.
So that was just an add-on.
Yeah, and adding in social, the information being spread over Facebook and these other social media sites, often some misinformation or information about, some condition like I'm sure the bed bug thing probably had a lot to do with being how we communicate with each other. And it's easy for something like that to get spread to a lot of people very quickly.
Absolutely. And it becomes this, almost belief conformity too. So extracting that from a genuine psychobiological effect.
Yeah,
it requires a lot of ingenuity.
I think there's some of this going on right now over to what extent is 5G and EMFs, what negative effects they're potentially having on health compared to what negative effects people perceive are happening that maybe aren't.
Yeah, absolutely. There was a spate of graffiti around where I live in my neighborhood, lots of 5G posters and everything else. And it creates a certain anxiety as well. And nocebo effect is one of these things that anxiety can be elevated with. You anticipate, it's an anticipatory response, as Cosima is saying. There's good evolutionary reasons why we have these anticipatory responses. So it's about preparedness for something, and signaling in whatever way that something negative is about to happen, we're attuned to that. So managing this on a social and a cultural level through mass media, social media, not to say anything about the doctor's office, if you will, it's a broader concern. What do we do from a public health perspective? How do we control messaging? Without sort of it's nocebo mind control messaging without interfering with people's lives. So how do we get into politics here?
Yeah, exactly. I tend to be a big free speech person, and I think it's a bad idea to just ban messages, take down YouTube videos that you disagree with. I think it's much more effective to just do a better job of spreading the correct information. I think good ideas, will overcome bad ideas. And if you simply take down the information and hide it from people, then people will feel like there's information that's being hid from them, and some people will be more attracted to it. So I don't think there's really a realistic way of stopping people from putting out some bad information. So I think the more we can get people educated, understanding how to analyze information, especially, about medicine or science, and how to figure out what is a good source, a good way to understand information, and that will be a better protection against bad information, I think.
I think education, right?
Right.
Education is really the word that you can also find in our book over and over again. I think also patient involvement. I think this is also why we are very much striving for patient involvement, also in research, right? So the more educated we are, the more we educate patients and the more we learn from them as well. So it's very important to not have this hierarchy, but to rather more be on the same eye level. And then I think you can start to learn from each other. And I think for the example with 5G, what we know from placebo is that this is something that we can also bring down to the so-called Bayesian approach. And there actually so the brain is always one step ahead. So we always anticipate. When you take a glass, right, you anticipate how it's been put on your mouth. And this is what you usually do. And this is very automatic. So, and what when you learn is only when you do an error. So only when my coffee spreads out, this is when I learn, I have done something wrong with my movement. And when you come to 5G, you would actually have to have a negative example why this is not the case. And this is so hard in these complex fields to learn from examples that really are a proof for you that 5G is not harmful. And this is almost not possible. So I think this is why it's a very, very complex field and why I really want to underline the importance of education.
Definitely. Yeah.
Okay, so to kind of wrap up, especially since my podcast is devoted to health, what are some of the main messages that can be learned from both patients and doctors and practitioners on how to avoid the nocebo effect?
I mean, one of them, from a medical perspective, I'm going to leave that maybe the medical side to Cosima to answer what can clinicians do. I would say from a patient perspective, one of the things that I've been interested in my research in digital health is online record access. And as we know in the US, with the 21st Century Cures Act, patients can get online and read their medical records. And they can see test results, and they can see a little bit of they can see the full narrative.
A little bit, to some extent, yeah.
So, well, doctors shouldn't be hiding this stuff. That's the point.
We've also created this big mess. When we set out to set up medical records, we decided, the free market is going to fix this. So there's 1,000 different companies offering 1,000 different online systems that are not compatible. And, we should have, I think, made sure that everything was built on a compatible platform so that, if you go to see a doctor at one hospital and you see a doctor at another hospital, those records are not shared. They're not compatible. And, what gets on there is somewhat limited. And part of it's time, part of it's other things, So you might get an X-ray. They don't put the X-ray on your medical records. You might have the doctor's note about the X-ray. Right. That's about it.
This is a whole other podcast that we could be doing.
No, I know. But it's too bad that the medical sharing is
the lack of interoperability between all of these systems. It's chaotic. But what's really interesting there is when you offer patients access, one of the things that they report benefits in are understanding the medical information better, including side effects of medications. Right. So this is a perfect vehicle. It's a perfect storm for increasing nocebo effects. So I guess from a patient perspective, I would say is that if you don't, it's really about the individual's preferences. If you don't really want to know, this is something that I have actually incorporated into my own. If I don't want to know this, I tend not to want to read the side effects sometimes of minor medications. If it's a bigger procedure, you want to know. But for certain medications, I just don't read. I don't engage because I don't want to tempt my own, underlying cognition to lead me astray into a whole set of problems that I don't need in my life. So how is it part of there? Yeah, that's my own lived experience, if you will. That there's so much transparency now in healthcare that nocebo effects could be elevated.
Yeah, you have that chapter on cancer where you mentioned that patients can go into their doctor and tell the doctor how much they want to know ahead of time before the doctor just tells them.
Yeah, that's another strategy. So that you're increasing you're strengthening the relationship with your doctor too, because you're letting them know what it is you want to know, and that can change, and it can change in a relationship with an oncologist as well, where you decide perhaps at the beginning you don't want that. Your decisions may change over time about how much information you want and when you want it.
What do we know about the medical legal aspect of that? Like if a patient says, I don't want to know, all the consequences of this medication, or I don't really want to know, what my likelihood of dying is. And then some legal situation holds up after that. Is the doctor...
I'm not a medical lawyer. I would want to weigh in on this.
I know that, but that's an issue that I could see making this situation complicated.
Yeah, but maybe I think it's so important when it comes down to, besides the legal issue, of course, empowerment, right? I think this is what Charlotte really outlined, how important it is to, when you give the patient an empowerment, and I think then this eye-level relationship happens. And right when it comes to the clinician side, I think this eye-level relationship is, of course, something where I would say this is what we can summarize from today, that we have a relationship that is trust-based. And again, with this empowerment, we also heard that the information, the way the framing is given is so important, to frame it positively or negatively. And this is actually also something where I would say this is hands-on, very easy. Yeah. The way you frame something, right? And I think the third thing is about expectations, what we have heard. So how can I look that the way I frame it creates positive expectations? So I think information, education, patient-physician relationship are three core elements of clinical practice changed in the way that nocebo effects can be minimized.
Great. Okay. Thank you very much for this important discussion. We've brought up as many questions as answers, but that's important to start thinking about this. And I think both patients and physicians can reduce the risk of nocebo effects by patients can tell their doctor what they want to know and the limits to which they want to hear negative information, and doctors have to find ways to correctly inform the patient, but frame it in a way that there's some emphasis on the positive aspects of it. I think you mentioned in the book somewhere is about a doctor explaining about to a patient who, most likely is going to die from a treatment, but frames it in a way that, like, I think 25% of the patients improve. And we're going to do everything to make sure that you're in that 25%.
Mm-hmm. Yeah. And that's critical to subsequent health behaviors too.
Right. Yeah, good. Okay, great. And everybody needs to go buy the Nocebo Effect book, right? Is it on sale now?
The pre-order, yes.
Okay, pre-order.
Yeah.
So release will be 19th of March?
19th of March, yeah.
Okay, and it's going to be available everywhere?
I know it's available on Amazon.
Okay.
Beyond that, I'm not, yeah.
Okay.
It's Mayo Clinic Press, so it should be available on Mayo Clinic's website too.
So the book is The Nocebo Effect When Words Make You Sick. Okay. Thank you.
Thank you.
Thank you very much. Thank you.
Thank you for making it all the way through this episode of the Rational Wellness Podcast. For those of you who enjoy listening to the Rational Wellness Podcast, I would certainly appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. That way, more people will discover the Rational Wellness Podcast. And I wanted to let everybody know that I do have some openings for new patients, so I can see you for a functional medicine consultation for specific health issues like gut problems, autoimmune diseases, cardiometabolic conditions, or for an executive health screen, and to help you promote longevity and take a deeper dive into some of those factors that can lead to chronic diseases along the way. And that usually means we're going to do some more detailed lab work, stool testing, sometimes urine testing, and we're going to look at a lot more details to get a better picture of your overall health from a preventative functional medicine perspective. So if you're interested, please call my Santa Monica White Sports Chiropractic and Nutrition office at 310-395-3111, and we can set you up for a new consultation for functional medicine. I'll talk to everybody next week.